Okay, thank you very much. I'm very glad to be here today. So today I'm going to speak to you about the advances in the treatment of SCFE and the use of non-fusion techniques. There we go. So I do have some disclosures. Obviously, I am a co-inventor of the FG screw, so I'm biased, and I don't think there's any real way to remove that bias. But otherwise, the rest of my disclosures have no conflict with this talk. So slip pathology, if we look at slip pathology, we know that the femoral neck slips off the head. Basically, the head stays in the acetabulum and the neck slips off and the metaphyseal slips anteriorly. We know that also there's an increasing incidence of slips due to the increasing obesity across the world. And in 2006, JPO published that the age of onset of slips is trending down. The natural history of a slip is that it will progress, and the deformity that's caused by it is a structural risk factor for hip dysfunction later in life. And the outcomes depend on both the degree of slip and the complications of the treatment we use. The goals of treatment are to stabilize the slip to prevent further slippage, and these are usually done by in situ fixation with either a fully threaded, partially threaded, or smooth pins in younger patients. In North America in particular, we have a tendency to close the physis to prevent further slip. And that's our standard, but should it be? There was an interesting study published in the Journal of Children's Orthopedics in 2017 from the Australian group with Dr. Little and Dr. LeBlanc. And they were looking at the considerations in slip capital femoral epiphysis and insights into the prophylactic fixation. And so they looked at fusion techniques in 30 non-pinned versus 60 pinned hips. And they noted negative effects on the center troch distance and the articular troch distance. And they concluded that there's a primary deformity from having SCFE that alters hip biomechanics. But there's also a second hit phenomenon of a secondary deformity that is created by our static fixation or our treatment. The consequences of fusing the slip, there's two parts. The primary deformity of the slip, which we just discussed, and that can cause femoral acetabular impingement, which causes early cartilage damage. But there's also a secondary deformity from fusing the physis, and that can create a high-riding greater trochanter, further decreased head-neck offset, a shorter femoral neck, and a limb length discrepancy. Treating those deformities is more challenging. So after slip stabilization, what are our options? Well, we can do osteotomies, which are not benign procedures, bumpectomies, and contralateral epiphysiodesis to deal with the limb length discrepancy. An alternative would be to do a surgical hip dislocation at the time of the slip, which is also not a benign intervention. And this still doesn't treat the secondary deformities of fusing the physis. So what are the other options? How can we allow the physis to remodel? Our current issues with our SCFE treatments are that the methods that we have that close the physis do not address young patients, the problem of femoral acetabular impingement, and secondary deformities of the hip caused by fusion, as well as contralateral limb length discrepancy. This is an example of a child. It was an 8-year-old girl who had an endocrine abnormality, had an acute slip on the left side, was treated with a fully threaded screw, and then developed a milder slip on the right side. And despite having fully threaded screws, because of her young age, she grew off the screws. And the physis stayed open, which is impressive. So what are the other options? And now, do we just go in and change her screws for fully threaded screws, which was likely at this point, 2 years later, close the physis? Despite what is thought in North America, allowing a continued growth of the physis is not a new concept and has been published on as early as 1988 by the group that developed the Hansen pin, and is peppered across the literature up to just the most recently, a few papers that came out. And this is an example of a mild slip in a 12-year-old boy. I had the opportunity to do my second fellowship in Australia with the Dr. Little group, where I was introduced to the Hansen pin. And so when I came back to start working in Montreal, This was one of my early cases, and I wanted to continue with this concept of allowing growth at the physis. And I can tell you it was met with a lot of resistance. And so this was a case of a 12-year-old boy that I insisted on trying the Hansen pin in Canada. And so this is a pin that's smooth. It goes across the physis, and it has a hook in it to hook the physis and stabilize the slip. The disadvantage is that you have to leave it proud so that it allows the pin to grow into the bone. But it's been published on for over 20 years follow-up by Dr. Hansen and the Swedish group, and it prevents further slip, and they use it in slips up to 60 degrees, and they leave the growth plate open. And so it's initially proud, as you can see here, and it allows for potential for the bump to remodel, some growth in the neck, and it decreases the risk of limb length discrepancy. And in this case, it really worked. You'll see that this bump looks like it's getting less prominent, and this is the example of the time of the slip, and this is a year later for this is 2 years later, and you can see that there's no significant limb length discrepancy. And so I think Dr. Ortegren is in the audience today, but I'm going to quote him for his two studies. The one that was published in 2016, where they looked at 57 hips between the years of 2001 and 2009, and they looked at femoral neck growth. And they saw that the average growth was 7 millimeters on the slip side and 10 millimeters on the contralateral pin side while using the Hansen pin. And they also noticed that there was 3 times more growth in the femoral neck in children that were under the age of 11 than those older than the age of 14. Again, the having to leave it proud is not always problematic in bigger patients, but in slimmer patients, it can be. In 2018, they published on the same group of patients, but then they looked at radiographic measurements of the head shaft angle, and they saw a mean post-op decrease of 9 degrees. And they looked at the alpha angle and saw an improvement of 14.5 degrees on the affected side using the Hansen pin. And they also saw a displacement from Klein's line that was increased by 1.6 millimeters. And of note, on the prophylactically pinned side, they also showed remodeling. And this is the directly from their paper, the data showing what I just discussed. There was another interesting paper published in 2017 in JPOB by the Korean group, and they looked at physical sparing approach in patients under the age of 10 years of age. And this was a comparative study with physical fixation. And they compared the physical sparing group and the physical fixation group and noted with regards to limb length discrepancy that in the physical spared group, there was a very minimal limb length discrepancy, whereas in the physical fixation group, the limb length discrepancy went up to 2.3 centimeters. For the femoral neck growth, they also noted continued normal growth and no significant difference from the non-affected side. And in terms of the remodeling of the alpha angle, they saw an improvement from 27 degrees to 4 degrees. However, because of the young age of the patients, most patients needed reoperation to change the screw because they used a medially threaded screw and left it proud laterally. And this is the data from their paper. So leaving the growth plate open has been discussed in the literature. The options are laterally threaded, medially threaded, a smooth pin, or a Hansen pin, and all involved either leaving the screw proud or a return to the operating room to change the screw. And they were fixed in the epiphysis or the lateral cortex, but not both. And because of that, extraction could be more challenging. And these are the different examples. This is where the idea of the free gliding screw came from. And as Ariel sort of alluded to before, I had the pleasure of doing my residency in Montreal with a lot of time spent at the Shriners with Dr. Fassier. And then I went to Australia, and the concept of leaving the growth plate open really came from my exposure to seeing the Hansen pin. And the combination of the two really gave birth to the concept behind the SCFE screw. So it's a self-extending 2-part cannulated screw that elongates with growth. It's basically the same concept as the Fassier-Duval telescopic nail, except that we reversed the male and female for stability. And it was designed for rotational stability as well, so the inside is triangular in shape. It's self-reaming and self-tapping, so that the female will have a better hold in the epiphysis, and I'll show that during the technique. The goal here is to allow for growth, so to prevent a limb-like discrepancy, allow the bump to remodel if sufficient growth is remaining, and it avoids protruding screw placement with other techniques for non-fusion treatment. And it stabilizes the slip, obviously. So the technique is not very different from other techniques of placing a screw. You place the guide wire in the correct position, and then you measure. There's two sizes. There's a 6.5 millimeter and a 7.3 millimeter diameter screw, and the lengths vary from 48 millimeters to 102 millimeters at 2 millimeter increments. At the time of measurement, we usually recommend adding 2 millimeters, and that's mainly to ensure that the female portion, all the threads of the female portion end up in the epiphysis. So following the measurement, we ream. You ream only up to the physis. We don't want to ream across the physis to prevent any kind of damage to the physis. And then the female and male portions are inserted together. And the most important portion really is to ensure that all the female threads are in the epiphysis, obviously without protruding into the joint. The extraction of the screw is also quite simple. We don't usually use the end cap anymore, and it's a cannulated screw, so the wire is back inside. Move them with the retriever. It has reverse cutting threads on it to help with the extraction, and it's the same for the female with the retriever with reverse cutting threads. So the telescopic screw, the goal here is to avoid physis closure. The growth of the neck helps to correct the deformity that causes FAI and prevent further damage. And it avoids the issue with screw protrusion, which other non-fusion treatments had. It also stabilizes the slip and has that rotational stability due to its triangular shape inside. It has an easier extraction. And in terms of the clinical experience, I will let Dr. Logan speak about, but the first clinical case was in the summer of 2014, and since then there have been approximately 1,000 cases across the world as of January 2019. So the real question is, does it work? This is an X-ray demonstrating 2 millimeters of growth and then 9 millimeters of growth in the same patient, showing that there is growth across the femoral neck. And then the second question is it strong enough? So this is there was a study done by the Australian group to look biomechanical study done to look at the strength, and they compared 4 groups. There was the negative control with a 30-degree slip, the FG screw in a closed position, the FG screw in a 2-centimeter open position, so slid open 20 millimeters, and comparing it to the Synthes screw. And when they looked at all their mechanical performances, they noted basically that it was shown to have equivalent or superior biomechanical performance in both the closed and the open configuration, with the added advantage, again, of allowing continued growth. So this is an example of an 11-year-old boy. This is an immediate post-op X-ray, and then at 18 months follow-up, and we can see here the growth at 4.5 millimeters on the screw. And an alternate way to look at this for those who are still not convinced about non-fusion techniques for the affected side is that some surgeons can fix the affected side with a threaded screw and use the physeal sparing approach on at least the contralateral side to avoid other deformities for prophylactic pinning. This is an example of an 8-year-old boy. He had an underlying endocrine abnormality. And so you can see there was a mild slip that was treated with the FG screw, and it's currently growing. The one limit of the FG screw is that the screw dissociates at 40 millimeters of length. So somewhere around 30 millimeters, one should consider, if it gets to that point, going to change the screw. And this is really for exceptionally young patients. This is an example of a 6-year-old male. He had a slip on the left side and then was prophylactically pinned on the other side at the same moment, fully threaded screws. At the age of 6, it's amazing how the physis doesn't close, and he grew off his screws, and now he's at the age of 9. The question is, what should be done? And so he had the FG screws put in, and we can see now continued growth on both of those hips. So the non-fusion, in my opinion, is better than in situ fixation in younger patients. It allows for slip stabilization in mild to moderate cases. And this telescopic screw allows for the physis sparing approach without the need to leave the screw proud. It's recommended in SCFE patients with remaining growth of more than 2 years. And so far, it seems that the studies are leaning towards showing femoral neck growth and remodeling of the head-neck offset. But I will let Dr. Logan talk to you guys further about that. Thank you very much.
Right, thanks, Mary. That was an excellent summary of and explanation of how we've got to the current situation. There was just as I listened to your presentation, just a couple of technique points that I think might be useful to emphasize. One is to ensure also, as well as the female threaded parts being completely in the epiphysis, that we have engagement to the lateral male threaded parts, because we have had instances where that male part's disengaged, hopefully before you wake the patient up, but I think on one or two occasions where it did post-operatively. And the other technical point with the kit is just to take time to ream and to clean the reamer often, because just the nature of the reamer means that forward progression is limited as the swarf gets caught in the thread. So two techniques. So we saw some extreme examples in Mary's presentation, the 6-year-old, the 8-year-old. And I guess the message that I want to put forward from our work here is that in mild slips in skeletally immature patients, this should really be top of the list in terms of the management if you want to preserve proximal femoral anatomy and avoid CAM deformity in the future. So we were one of the first centers in the world to use this screw. In fact, my colleague, Dr. Ben Orlick, I think may have been the first person to put this screw in, and may have done more than anyone else at our institution. Kevin Morash, who is off to Point this year to do his fellowship, did the majority of the work here on this retrospective study. We're hoping to have him back in Halifax if the stars align. Dr. Ron El-Hawari, who many of you know from the spine world and also from CPOG, and Dr. Luc Gauthier. We all contributed cases and insight into this study. So this is a retrospective single-centered study done at the IWK Health Centre in Halifax, which is the Children and Women's Hospital. We basically reviewed all cases of in situ pinning for stable SCFE since October 2005. So we included slipped hips, prophylactically pinned hips, as well as we studied the control hips, which were the essentially untreated hips. We did in situ pinning with the FG screw, either the 6.5 or 7.3, and standard Synthes cannulated screws, 6.5 and above. And we excluded patients with unstable slips or who had a reduction attempt or had alternate implants to this. And so we ended up with five groups: the SCFE and the group, which had FG and standard screws; the prophylactically pinned hips, which had either FG or standard screws; and the control group that were unpinned. The radiographs were reviewed as part of the study immediately post-op and at 1 and 2 years. And we had presented this work last year, and we've added a few more cases since then as they've hit that 2-year mark. We did AAP pelvis, on which we measured articular trochanteric distance and screw length. And we also did a frog leg lateral, on which we measured alpha angle and head neck offset ratio and head shaft angle. And you can see in the images below examples of how we did those measurements. So in the free gliding screw fixation group, in total, we had 32 patients, 19 slips, and 13 prophylactic patients. And then in the standard screw fixation, a good deal more patients, with 63 in the SCFE group. And these study groups were relatively well matched if you look across sex, laterality, and slip severity. The majority, if you look at the mean slip angle, the majority of these slips were mild slips. And that's important as we go on through the results. So we found that in the slips that were pinned with the FG screw, that they did show a statistically significant greater 1-year remodeling than hips that were pinned with the standard screw, that actually did still show remodeling, but not at the same rate in terms of alpha angle as the fusion techniques. So we could see that the alpha angle in the SCFE hips improved on an average of approximately 13 degrees versus 4 degrees using a standard screw. So we're actually in doing that, we're actually taking the alpha angle down from a pathologic abnormal measurement to largely within the normal range in most of these slips, which I think is very significant. We also looked at greater trochanteric overgrowth by measuring the articular trochanteric distance. And we found that in slipped hips that the ATD decreased both in FG and standard hips. But in prophylactically pinned hips, where the ATD decreased in standard screws, FG and control hips remained unchanged. And this really speaks to Mary's point that if you're going to pin a normal unslipped hip in a skeletally immature child and you want to maintain the proximal femoral anatomy, you should really look at a growth sparing device. In terms of screw lengthening, compared to some of the Hansen studies and that Mary quoted, in fact, that initial Hansen study, I think they had lengthening up to 15 millimeters, 15 to 18 millimeters. And there may even have been the odd case that was longer than that. I'm not sure if it was included in that particular study, but certainly very significant neck growth. We didn't see that neck growth in our population. It may be because this was largely your standard kind of SCFE population. It wasn't your young patients who are presenting with endocrine abnormalities like the 6-year-old and the 8-year-old, but this was the 11, 12-year-old male and female population. And we did find that FG screws did lengthen more in prophylactic hips than SCFE hips, so around a 5 millimeter average lengthening in a prophylactically pinned hip versus a 2 millimeter in a SCFE hip. And but that was still significant, still resulted in a significant decrease in alpha angle. So in all of our patients who had greater than 2 millimeters screw lengthening, they had very mild slip. So again, this supports the premise that in the mild slip, the FG screw is going to be more effective in allowing neck lengthening. That may be because of the pathology of the physis and the slip. It may be because the orientation of the physis. We really don't know the answer to that. It's all theory right now. So just a couple of case examples. So this is a 10-year-old boy who had bilateral slip capital femoral epiphysis, both mild slips. And if you follow the X-ray images from left to right, you can see quite significant lengthening of the FG screws bilaterally. And here is a 12-year-old patient, bilateral SCFE, so a mild slip on the left and a more significant slip on the right side. And we can see on the left side that we had more significant screw lengthening than on the right, likely because of the severity of the slip. So in conclusion, I think the FG screws allow greater femoral neck remodeling than standard screws. FG screws lengthen most when treating mild slips and when prophylactically pinning. And FG screws also minimize iatrogenic deformity, i.e. loss of the articular trochanteric distance when prophylactically pinning. So I'll be happy to take any questions at the end. And I think Kishore is going to follow on. Kishore.
Thank you. Good morning, everyone. As Ariel said, we go a long way back, and most of my involvement with PEGA is predominantly using FD nails, but I also happen to be a part of a slim nail design that Ariel was kind enough to give me an opportunity to get involved. Slip registry. So this concept came from our experience with doing a registry for DDH, development dysplasia of the hip. And the history with the registry for SCFE was actually done in late 1990s and early 2000. And I've actually learned a lot from that. And I think Dr. Diaz had insight to publish why that slip registry initiative failed. And it's actually, those of you that want to look up, it's actually published in JPO. And any of you that are trying to set up a large multi-center study, I think it's worth reading that paper. It actually talks about failed attempt to form a slip capital femoral epiphyseal registry. And learning from our lessons from DDH registry, so we wanted to get this registry off the ground. And I must admit, I think the first kind of encouragement came from Ariel and PEGA Medical, and they've given us an unrestricted education grant. But we did mention that we would be recording not just the free gliding glue, but anything or any treatment or any kinds of treatment from anyone in the world. So this has obviously some data on the free gliding screws in this registry, but really it's an open slip registry that anyone can participate in, truly a global registry. So I'm the PI for this one, and we have a co-PI, Eduardo Novias from Boston Children's Hospital. Emily Schaefer, she's a PhD scientist and research director at BC Children's Hospital. She's really the heart and brain behind most of our registries and really leads our HIPPY research team. And the coordinator for this is Ashley Manoz. I do have several disclosures. I work very closely with several industries, and a large part of our research efforts are funded by not one, but many industries, as you can see here. So the objective of this registry is very simple, really develop an observational cohort of different treatments from different parts of the world. And the goal of any registry really is to first try and see if we can work together in a multi-center setting, and then see if there are any opportunities there are to do a specific hypothesis testing studies. And we're actually embarking on that in DDH. So we've had a DDH registry now for about over 6 years. And we're designing about 3 randomized controlled trials, one to look at mild radiological dysplasia versus leaving them versus treating them with brace, a rigid versus a flexible brace, and really looking at traction versus no traction. And so, what registry does is gives you a framework to continue to collect prospective data. And if a select few centers are willing and they have infrastructure to look at more sophisticated studies, and you actually have a platform to do that. And currently we have 187 patients and potentially from 26 participating sites, 5 countries and 4 continents. And if you have colleagues and friends that you don't see these centers that I'm going to talk about, or you're at a center where it's not represented, please do reach out to us. And the invitation is open for anyone, any center, anywhere in the world to be a part of the registry. So currently, these are the centers that are part of our registry right now. And if you don't see your center as yet, probably your center is actually recruiting, but we haven't finished either ethics or FDA, a data sharing agreement with your centers. For example, if you look at IWK, we're still working through some of the data sharing agreements with them. And they largely right now, once that's done, will be one of the large contributors to this registry. These are all the centers now, as you can see, from Korea, Netherlands, Italy, Costa Rica, China, Argentina. So anyone that you notice here that if you don't see one of your colleagues or you're from a center, you don't recognize your center's name, please do reach out to us. We're quite happy to involve you. And this is the recruitment right now of different centers that have contributed patients. And again, if you don't see your center and you're actually part of the study, that means we haven't done our data transfer agreements yet. And sometimes these do take a time. The average time from a center expressing an interest to them being actually finally entering a patient into our database, the quickest we've ever seen is 6 months, but it'll be more like a year to 18 months. So it's quite a process. And if you want to get involved, start now. The other concept that I want to leave you with is this concept of a HOPE network. HOPE stands for Health Outcomes in Pediatrics. And this really stemmed from us thinking about different study groups. As you can think about, pediatric hip is a pediatric hip. And some of the learnings that we have are transferable from one to another. But we have prospective study groups that work in silos. For example, POTI study group, DDH registry, SLIP registry, anchor group, and so on and so forth. And the CHOP, which is the Cerebral Palsy Health Outcomes Project. How do we bring expertise of pediatric hip experts under one umbrella so we could exchange knowledge? I'm talking about not just pediatric orthopedic surgeons, physiotherapists, engineers. And so we have a buy-in from 28 different pediatric orthopedic societies around the world. And we've just in the ground zero, forming of the network, to think about what the network structure would look like. And so some of the purposes are idea exchange, increase international collaboration, identify research priorities and direction. And the reason I say that, even with our real attempt to try and get other centers from other parts of the world, and most of the medical research is published, about 90% of it is from the developed world. That constitutes less than 15% of the world population. And the developing world contributes to less than 10% of scientific research that there is, or even collaborators on less than 10% of the research. So those of us that involved now in the discussions about diversity, inclusion, equity, equality, we need to ask ourselves, how much is our research relevant to the world? Is your research, if you talk about yourself as a multi-center international study groups, and I would say the early part of even our study group, we called it international. We were basically UK, Australia, and Canada and USA. At best, it's English-speaking, colonial, but it was truly not international. So our efforts right now with our registries, our networks, is to really get to that marginalized children, marginalized populations that live in the rest of the world that don't have an opportunity to engage, participate, and benefit from, and for us to learn from them. So that's really the concept of these global networks, is how do we really help and learn from the rest of the world? And this is roughly the network structure. So as you can see, there are several HIPs that we're not studying at the moment. One of the examples that I can give is SMA HIP, and we've been largely nihilistic with dealing with them. But now the phenotype is changing. A lot of these patients are surviving, and some of us are beginning to operate on these. But there is not a study that looks at what the outcomes are. And so that's one example. Or if you look at post-septic sequelae, the best papers that come out is from Korea. But other than that, there's a lot of post-septic sequelae that's being seen around the world, but there is no way that we've been looking at and trying to understand prospectively. The largest femur fractured neck or hip dislocations that are prospectively looked at is in probably high 20s. And there's no meaningful conclusions that can be drawn from studies like that. So this would be one-stop shop for people to come and exchange ideas and to learn from each other and then to participate. So if you are a pediatric hip surgeon and interested in participating in this network, do reach out to me. So here's an example of the different pediatric hip conditions that there are. So you can see, we barely are scratching the surface with 3 or 4 different hip conditions. So if you're interested in joining either a SLIP registry or this network, do reach out to our coordinator or myself, and my email is here. We're quite happy to include you in our registry efforts, and I'm looking forward to collaborating with you and learning from you. We're funded for this registry by multiple different sources. We're really excited about this initiative, and if you're not already familiar, so just go look up I'm a hippie. So we call all of our hip surgeons around the world that participate, we call them hippie surgeons. And if you're a hippie, do reach out to us and become a hippie with us. And we're also excited about a large funding that we received from this very generous family for global hip health, the Peterson Fund for Global Hip Health. A lot of our efforts in India are actually now supported by corporate social responsibility funding from a lot of the Indian corporates. And a large funder is actually our research institute. And I can't thank enough Pega Medical to really actually to think bold about starting a large registry. So thank you, Ariel. Thank you, Fadi, and the Pega team for not just in asking us to look at the results of just this crew, but really allowing us to be global, allowing us to really think broad. Thank you.